Hi, I'm John, your host, and welcome to Heart of Care, a podcast by ANCU. Here, we delve into the real voices of healthcare, sharing stories of resilience, humanity, and the unwavering heart that drives it all. Join us as we empathize, learn, support, and even find moments to laugh together. Thanks for being here.
Podcast Heart of Care. Episode 10. The Unseen Hurdles, Empathy, Ethics, and the Everyday Doctor. The Mistake That Stayed With Me. A Doctor's Personal Reckoning. Welcome everyone to The Unseen Hurdles, the podcast where we pull back the curtain on the real, raw, and often unacknowledged experiences in medicine. We aim to explore the profound complexities that lie beneath the surface of a doctor's daily practice. The ethical dilemmas, the systemic pressures, and the deep emotional toll that this demanding profession can take. Today, we're honored to have a very special guest with us. Dr. Evan Hope, a dedicated general practitioner. He's here to share a story that profoundly impacted his practice and his life. A narrative of a perceived diagnostic challenge, the immense weight of professional responsibility, and the arduous yet ultimately healing journey of self-forgiveness amidst public scrutiny. Dr. Evan, thank you so much for your incredible courage in opening up and sharing this deeply vulnerable experience with our listeners today.
Thanks for having me, John. It's not an easy memory to revisit, as you can imagine, and the emotions are still very much there. But I truly believe these are the crucial conversations we need to have within our medical community and with the public to truly understand the human side of medicine and the challenges we face every single day.
Let's dive in then. Can you take us back to that particular day, Evan? Describe the patient, the initial consultation, and what made that encounter so uniquely challenging.
I remember it vividly, John, as if it were yesterday. The clinic was busy as usual. A family came in and they were quite concerned because the school nurse had specifically urged them to present to a GP. The main complaint was that their child was going to the toilet many times. But, and this was a critical detail, not every single day. It wasn't a consistent, unrelenting frequency that screamed alarm bells. In fact, the mother herself voiced her suspicion, saying, "Sometimes I just think he's mucking around." This immediately added a layer of ambiguity to the presentation. What made this consultation particularly challenging was the almost complete absence of the classic textbookered flag symptoms for type 1 diabetes that we're all taught to look for. There was no polydipsia, no complaints of excessive thirst that the parents had noticed. The child wasn't particularly tired or lethargic, which is often a key indicator. There was no family history of diabetes, which can sometimes provide a genetic clue. And crucially, there were no unusual rashes or recurrent infections, which can sometimes be subtle signs of undiagnosed diabetes. When I asked the child directly, he denied having polyuria, which is the actual excessive production of urine, and he reported no specific urinary symptoms like burning or pain. It felt like I was piecing together a puzzle with half the pieces missing. We had a long consult, probably stretching well beyond our typical 15-minute slot, as I tried to elicit every detail. I performed a thorough physical examination, methodically checking for anything that might point me in a clearer direction, looking at his general appearance, checking his skin, his abdomen. But nothing really jumped out at me as a glaring, undeniable red flag. It was a subtle, nonspecific complaint that could have been many things, and that's often the reality of general practice. You're dealing with the early, less defined presentations of serious conditions.
So, it wasn't a textbook case of diabetes presentation by any means. You were dealing with a very nuanced, ambiguous picture. How did you then decide to proceed with your investigations, given that lack of clear signs?
Despite the absence of those screaming classic signs, as a GP, your clinical mind always has to consider the worst-case scenarios, however remote the likelihood might initially seem. Type 1 diabetes, especially in a child with altered toilet habits, is always a condition you must keep in your differential diagnosis. It's a serious condition, with potentially rapid progression. So, my decision was to be comprehensive. I explained to the mother and child what I was looking for, why it was important, and the potential serious conditions we needed to rule out. I explicitly ordered some blood tests, a full diabetes workup including fasting glucose, insulin, and HbA1c. I wanted that definitive lab confirmation.
And then came that critical, very human moment with the finger prick test. A quick, on-the-spot check that, in theory, could have provided immediate answers, but encountered significant resistance.
Yes, John, that was perhaps the most agonizing and ethically challenging part of that initial consultation. I really wanted to do that finger prick, right then and there. It's quick, it's efficient, and it could give me an instant capillary blood glucose reading. Immediate insight. But the child heavily resisted. He was visibly anxious, quite scared, and just not keen on having his finger pricked at all. And the mother, understandably, perhaps sensing his distress, or having her own concerns, also wasn't keen. She said, "Oh, doctor, better to do it later." And you're in a very delicate position as a GP, especially with children. You can't physically force a child to undergo a procedure against their will, particularly not without explicit parental consent and cooperation. Pushing too hard against a parent's clear preference, especially when they're already distressed or hesitant, can break that vital trust you've worked so hard to build. That trust is paramount for future care. So, I had to make a judgment call. I decided to prioritize trust and patient comfort in that immediate moment while ensuring safety. I spent more time explaining all the potential red flags again, really emphasizing what to look out for, what symptoms would mean go to hospital immediately. I spent more time explaining all the potential red flags again, really emphasizing what to look out for, what symptoms would mean go to hospital immediately. I stressed the importance of follow-up once the blood tests came back. And even though a urinary tract infection seemed very unlikely given the absence of specific symptoms and the sporadic nature of the complaint, I still asked the child if he could provide a urine sample, just to cover all bases. He immediately said he didn't want to. I didn't push. Then the mother offered, "If I ask him at home, he'll do it. I can bring it in tomorrow." It was one of those classic moments in general practice where you're constantly negotiating, gently pushing for best practice, while respecting a child's comfort and a parent's trust. We don't always get immediate results, but we try to cast a wide enough safety net without breaking that crucial therapeutic relationship. My thought process was, okay, I can't get definitive answers right now, but I've covered serious possibilities with clear instructions, a pathology plan, and good safety netting. In that specific context, it felt like the safest, most responsible, second best option.
4. The unforeseen diagnosis and the public shaming. So, the blood tests are ordered, safety netting is in place, and you're waiting for the results. What happened next, and what was the unexpected turn?
The unexpected happened, John. Just 2 days later, the family ended up in hospital. But not for the symptoms I was initially investigating. They went in with an upper respiratory tract infection, something completely different. It was an intercurrent illness that often unmasks underlying conditions. However, during their hospital checkup, my blood test results that I had ordered and sent a couple of days prior became available. The hospital noted them, and that's when the type 1 diabetes mellitus was definitively confirmed. The child was well, thankfully stabilized after an IV drip, and later discharged, which was a huge relief, of course.
That's a relief for the child. But then came the professional blowback, didn't it? That must have been an incredibly tough experience for you.
It was utterly devastating, John. The pediatrician who saw him in the hospital and noted my test results was really disappointed. In fact, they were quite vocal about their disappointment, feeling I should have picked it up 2 days earlier. And because it's a small town, word spreads incredibly quickly. Suddenly, all the pediatricians, the ED physicians, they were made aware of my mistake. I received a phone call from my head of department saying I should be more careful and suggesting that a urine dipstick would have been positive and faster. In hindsight, that comment truly made perfect sense, and it immediately made me feel even more foolish, even more inadequate for not thinking of it then. That public criticism, delivered by peers and superiors, was incredibly undermining. From then on, every referral I made to pediatrics felt different. They'd demean me, questioning my judgment. Why didn't you do this? Why didn't you do that? I even heard from colleagues in that department that they were making fun of how bad I am in their meetings. They went so far as to formally complain to the head of the hospital and the head of my own clinic. It was a complete public shaming, and it just wore me down. I kept questioning myself. How often is T1DM diagnosed in the community in such an early, non-specific stage? And how often is it picked up by a GP without classic symptoms? I had ordered the full DM workup. I had called the patient immediately when the results came back. I had written the referral. I didn't feel I'd done terribly, but the constant criticism just chipped away at my confidence.
5. The emotional reckoning and finding healing. Evan, that level of scrutiny, that professional humiliation must have been crushing. How did you even begin to cope with that kind of emotional burden?
It broke me, John. I remember that day vividly, coming home just collapsing. I curled up, crying in my bed, feeling so utterly dumb, so ashamed of myself. All the good decisions I'd made for days, weeks, months, all those positive patient outcomes, all that hard work and dedication, just seemed to be completely wiped away by this one incident. I felt so bad, so profoundly depressed, so utterly ashamed. It's a weight that's almost too hard to describe, a feeling of inadequacy that infiltrates every corner of your professional identity. You feel like a fraud, that you've let someone down, and that your fundamental competence as a doctor is completely undermined. It makes you question everything.
That's a very raw and honest description of the toll it took. But amidst that darkness, you eventually found support and ultimately a path to forgiveness, didn't you? Can you tell us about that journey and who helped you through it?
Yes, thankfully the support I received was pivotal. My supervisor was truly my rock. He sat me down, looked me in the eye, and said, "Evan, if I were you, I probably would have done the exact same thing. You picked up a rare diagnosis, and you acted safely. We don't have the luxury of a 30-minute appointment, with interns, residents, and a lab, just down the hall like they do in hospitals." He told me not to beat myself up over it. And hearing that from someone I respected so deeply was incredibly powerful. It was the first real step in lifting that immense weight off my shoulders. My colleagues, too, rallied around me. They'd come over, give me a pat on the back, and offer quiet words of empathy and solidarity. That sense of professional brotherhood was deeply healing. And at home, my family stood by me unwaveringly, offering love, perspective, and gentle reminders of who I was beyond the clinic walls. Their strength held me together when I felt like I was falling apart.
And perhaps the most unexpected and powerful healing came from the family of the child involved, the very people you worried you might have let down.
That was truly the most humbling and powerful moment, John. After many weeks of self-healing, supported by my family and colleagues, I was finally able to start forgiving myself. And then, the patient's family, they reached out. They told me, "Doctor, you have done what you can. We trust you. Please don't be hard on yourself." To hear those words from the very people affected, to know they understood the complexities and still held that profound trust in me, was an incredibly powerful moment of redemption and peace. It allowed me to truly make peace with the situation, to accept that I did my best given the circumstances. I learned an invaluable lesson from it, and that I can always strive to do better, but without that crushing self-blame.
6th conclusion: the human imperfection of medicine. Dr. Evan, your story is a profound testament to the impossible standards doctors often face. As you reflect on it now, is it truly realistic to expect perfection, or to get everything right on the spot every single time in general practice?
Realistically, John, no. It's simply not possible. You're seeing patients every 15 minutes, sometimes for 8 or 9 hours a day. You're making hundreds of high-stakes decisions, often with limited information, patient resistance, and within a strained system. There is no way you're going to get everything perfectly right, on the spot, every single time. the core of what we do. What truly matters is that we are there day in and day out. We are trying to make a better world for our patients. We are saving a lot of lives, and we are preventing a lot of suffering and death. This one incredibly painful experience, while it will always stay with me, has ultimately made me a more cautious, a more empathetic, and fundamentally, a better doctor. It's part of the continuous learning journey.
Dr. Evan Hope, thank you for your profound honesty and for sharing such a vital perspective on the human imperfection, the immense pressure, and ultimately, the resilience required in medicine. Your story will resonate deeply with countless listeners.
Thank you, John. It's an important conversation to have.
If you're a doctor or medical student struggling with a similar experience, please know you're not alone. Seek support, learn from your experiences, and most importantly, extend yourself the same empathy and compassion you so readily offer your patients. You are human, and your dedication is valued. Join us next time on The Unseen Hurdles as we continue to explore the often hidden challenges of healthcare. Thanks for tuning in to this episode from AMCU Media, where real stories, healthcare, and advocacy come together. We release a new episode on the 28th of every month. We're a small, independent team doing our best to bring you meaningful conversations. And your support means the world to us. Subscribe to our YouTube channel and Facebook page. Just search for AMCU Media. Got a story or topic to share? Email us at amcu@strmedical.com.au. Together, we can do better. For care, for community, and for change. Until next time, thank you. And take care.